heart failure and compression therapy pathway. So I'm Penny Rubio, and you can see there, I hope, Jenny J. I'm the clinical lead for tissue viability, and Jenny is the clinical lead for the heart failure service. And we came together over 2 years ago now, before COVID, in fact, possibly close to 3 years ago, with questions of, I've got this patient with edematous legs, and people are saying that they want to put compression on, or we want to put compression on, but they also have heart failure, and how do we manage that? And we realised that there was a lot of people were sort of quite anxious about making a decision as to whether having compression on with heart failure was okay. And we did hear as well that other places in the country actually don't allow compression to go on somebody with heart failure. Right, next slide. So Jenny was speaking to Gabby Parham, and we got a draft of some of their concerns, and we realised that our position was quite the opposite to the heart failure team's position about whether it was okay to put compression on an edematous leg in somebody with heart failure. So we decided that we needed to do some work, that there needed to be some guidance, that we weren't going to revert to you can't do it, and therefore leaving some people with very swollen legs weeping without any intervention. And this pathway is the result of that. So it is loaded onto the tissue viability website. The address is there. It's on the internet, not the intranet. So that means that you can Google from the comfort of your sofa on a Friday night with a glass of wine in your hands. And if you just Google Oxford Health and tissue viability, you will find our website. You don't need to remember the web address. And then you'll see that there's a series of tabs that you can click on. You are looking for the lower limb tab. And when you've clicked on that, if you scroll down, you'll see another thing to click on called compression therapy. And you will find this pathway and the guidance and monitoring form that goes with it there on the website. Okay, so from a tissue viability perspective, what do we think about legs that have got lots of fluid in them? So we're concerned about this, particularly if it's been there for more than 3 months. We call this chronic edema or lymphedema. And what we know is that regardless of why it's there, if that fluid has been in the limb for 3 months or more, and it's not relieved by elevation or diuretics, we know that there is a high risk of limbs like that getting problems such as fungal infections, cellulitis, and risks of sort of leg ulceration. So it can be for a variety of reasons why people get fluid in their legs that's there over 3 months. It can be the commonest one in our world, in the tissue viability world, is when people have problems with their venous system, or they have problems with the lymphatic systems. And what we see is that when the edema has been there for a period of time, it starts to cause some skin changes. And you can see in the top photo, this edema has been there a very long time. You're getting skin folds and hardened fibrotic skin, and high risk of skin infections and ulcerations. And leaving it there in our world is not a good idea for those reasons, really. It is costly to patients because having large legs or that are weeping or ulcerated or that have cellulitis has a really horrible impact on somebody's sort of quality of life. Risks of cellulitis, sepsis from that, hospital admission. So when we see legs like that, we say, that's not good. We want to put compression on to move the fluid to reduce the risks of these things happening. It's not only costly to patients, but it's also costly to the health service if we don't do anything about it. Because those large, wet, weepy legs that where these legs often end up has the rest of us sat on our knees in front of people for hours on end, doing back-breaking bandaging, all taking up a lot of time and resources. So from a tissue viability perspective, when we see legs with edema in, what we say is, it's not a question of whether we can or can't compress the legs, but more a question of how much compression is safe. So our baseline is, we're going to compress, how much is safe? Now, that might not be quite the same as what heart failure think about seeing legs like that.
So yeah, as Penny said, we felt we needed to do some joint work on this. We see quite a lot of patients out in the community with swollen legs, and a lot of them will have district nurses coming in. And sometimes we've had occasions where the patients have been having their legs dressed for months, if not years, without knowing that there was a heart failure diagnosis going on in the background. And once the heart failure had been diagnosed and they're on appropriate treatment, the fluid goes and their legs heal up and they no longer need any dressings. So I don't want to be too basic. I'm not quite sure the level of sort of heart failure knowledge out there, but the heart is a muscle. It pumps blood around the body. Heart failure occurs when the heart muscle doesn't function normally. So that can lead to fluid retention, or it can be a reduction of blood flow. So you can have many problems with the heart muscle. So the heart contracts, which is systole, and it relaxes, which is diastole. So you can have problems with the heart contracting. So the strength of the heart muscle contracting, it doesn't pump out very much blood each time it contracts. That would be systolic dysfunction. You can have problems where the heart doesn't relax properly. So it's quite a stiff heart. It often happens in hypertension, where that muscle just doesn't relax. The heart doesn't fill very well, but it's got an excellent contraction. So it pumps out beautifully, but it hasn't filled. So you haven't got much blood in that ventricle to begin with. It could be a valve problem. So the valves sit between the atria and the ventricle, and they also sit where the blood enters back out into the lungs or into the aorta. If they don't close properly, you can get backflow. Blood should go one way through the heart and the two sides don't join. But you can sometimes, if the valve's not closing and the pressure rises, blood goes back up from where it comes from. So it can affect both sides of the heart. It can affect either or both. It nearly always starts on one side, but eventually it will affect both sides. So thank you, Penny. So blood returns to the heart via the venous system. So it's goes back up towards the heart via the vena cava. If there's too much pressure in the vein, so if that heart isn't pumping effectively, you're going to get backlog of blood. And depending on which side of the heart is affected will depend on where that backlog will happen. So too much pressure builds up in the veins and fluid leaks out into the tissues. Gravity will cause fluid to move to parts of the body that are lowest, which is why usually when you see edema in a heart failure patient, it usually is in their feet and ankles. That's where it starts. As the swelling gets worse, it will spread up their legs, knees, thighs, groin, waist. You know, it can go all the way up. If the left side of the heart is failing, pressure will build up in the veins of the lungs. So that causes the fluid to leak into the lung tissues. So when blood comes to the heart, it's just come from the lungs. It's full of oxygen, oxygen-rich blood. It goes to the heart, but if that heart's not pumping it through, the backlog is into the lungs, and it's the lungs that take the brunt of it, which are your very breathless patients with lots of bubbly fluid on their lungs. So that's the pulmonary edema, cough, frothy, bubbly sputum. If it's the right side of the heart, then it's usually down in the legs that you'll see it, but you'll see it with right and left swollen legs. So the general consensus for as long as I've been doing this job really seems to be with heart failure patients, you avoid compression. We've had this mismatch, you know, the district nurses or tissue viability will come to us and say, we've got this patient with heart failure, we want to put compression on, and our bog standard answer was always no. And we felt we needed to meet in the middle because actually compression is very beneficial and it's looking at each patient individually. There have been some studies, there's not many, but they're very small scale, but they do show that compression in heart failure patients does increase right atrial pressure. So we do know that it can cause worsening sort of pressure on the heart, which is why we've always said to avoid it. But I will let Penny carry on.
Okay, so you can see how we got into this sort of situation with tissue viability on one side saying we need to compress, and the heart failure team on the other side saying we should avoid compression at all point. And it's how to find a middle ground where we can manage symptoms without taking too high a risk with worsening somebody's heart failure. So this is a copy of the pathway that we sort of put into place. This has been through, it's been to cardiology, and cardiology have signed it off. It's been through the trust, and the trust have signed it off. And basically, this is to help guide you when you have a patient and you're thinking, gosh, is there heart failure? And oh, there is heart failure. Is it safe to compress? If you follow this pathway, it then covers you for anything that may be, you know, any problems that you might have. So it's also your support from the trust, if you like, and from ourselves. So it's your permission to go ahead and put compression on as long as you've followed the pathway and gone through all the stages that it recommends. So this is the document that you'll find on the Tissue Viability website, on the lower limb portal, on the lower limb tab underneath compression. So we're just going to go through this in bits now and talk you through it. So starting from the top, so whether you're a district nurse, a practice nurse, you work in a community hospital, whether you're in one of the and anywhere in Oxford Health basically, and you're approaching a patient who's got swollen edematous legs, and they're not currently in compression, you need to do a full holistic assessment. So you should be aware that there is a chronic edema pathway produced by Tissue Viability about how you manage a limb with chronic edema compression wise. And you'll see on the bottom of this slide, the yellow pathway there is the chronic edema pathway, and there's details on there about what assessment you should be undertaking for that. As part of that assessment, you're going to be looking at, is there a diagnosis of heart failure in the medical record? But before you get to that point, if you find that you've got a patient that's already in compression and you discover that they've got heart failure or a new diagnosis of heart failure, you don't take the compression off at that point. The risk with the compression with somebody at heart failure is in the moving the fluid from the limb back into the circulation, increasing the circulatory volume and causing pressure on the heart. But if you've already got the bandaging on, that wave of fluid, if you like, has already happened. So don't take it off if it's already on, because all you'll do is put yourself into a difficult situation, because you'll take the compression off, the fluid will come back into the legs, and then you're in the problem of, gosh, now I want to put compression back on, but it's going to cause this sort of like wave of increased sort of circulatory volume. So don't take it off if it's already on is the thing. So when you're looking to see if somebody has a diagnosis of heart failure already, you will find that there are very many descriptions that there could be, and you'll need to look thoroughly into somebody's medical record, because you may see things like lots of initials and short stuff. So HF, heart failure, CCF, congestive cardiac failure, LVF, left ventricular failure, LVSD, left ventricular systolic dysfunction. Now this is where it all gets a little bit complicated. HFrEF. Go on, take it away, Jenny.
Heart failure with reduced ejection fraction. And HFpEF is heart failure with preserved ejection fraction. They're the new terms for heart failure in the NICE guidance. So I say new, they're about 2 to 3 years old now. The ejection fraction is the volume of blood that the left ventricle ejects every time the heart contracts. That ventricle never empties completely in anyone. In a normal person, the ejection fraction is about 55 to 60%. So every time somebody with a normal functioning heart, that left ventricle contracts, 55 to 60% of the volume of the blood is pumped out into the aorta. So what we do when they have an echo to see if they've got heart failure, they measure the ejection fraction. So you can have heart failure with a reduced ejection fraction, so that would be 40% or less, which are the group of patients that our team is commissioned to see. But you can also have heart failure with preserved ejection fraction. So they're the ones I was telling you about with the really stiff heart. Doesn't feel very well, pumps brilliantly. So the ejection fraction is very good. They've still got heart failure because they don't fill. We at this stage, as of today, are not commissioned to see patients with HFpEF. There is a business case out there saying we want to see all. Diastolic dysfunction is an old term for HFpEF, same thing. Like LVSD is the same thing as HFrEF, but you'll predominantly see LVSD and HFrEF written in the notes. And then RHF is right-sided heart failure, which usually is secondary to lung disease. Pure right-sided heart failure on its own without left-sided heart failure is secondary to lung problems. We don't see them either, but they will still present with the same symptoms.
Brilliant. Thank you for that. So all of those things you might need to be looking for. And at the beginning as well, we're asking you to record a baseline blood pressure, pulse, resps and current weight for these people too, because we need to be assessing whether when we are putting compression on, whether we're impacting on all of those. So if there is a diagnosis of heart failure, there'll be one pathway off to the left, the red pathway. If there isn't a diagnosis of heart failure, we'll be off to the right onto the blue pathway. So, Jenny,
so if
this is the blue, sorry, we're off onto the blue pathway now. So if there is no diagnosis of heart failure in the medical record, you need to follow the blue pathway to see if this might be a new diagnosis of heart failure that hasn't actually been picked up by anybody yet. So there we go.
Because yeah, we do see lots of patients when they're newly diagnosed, when you look back at their history, they will have had swollen legs for months, years sometimes. So it often is their first symptom, but there are so many reasons why people get swollen legs. We don't always assume that everybody with swollen legs has got heart failure. So there are some red flags to look for. If they've got a history of ischemic heart disease, so if they've had an MI, they've got angina, any heart rhythm problems, atrial fibrillation is very common. I think 1 in 4 of the over 70 population has AF. Any arrhythmia at all. So you might see, other than some people have had VT, or they might have had an ICD in for a long time. Any other cardiac diagnosis at all. History of hypertension, history of diabetes, those two very commonly can lead on to heart failure. So that's what sort of medical history you're looking for in the notes. Symptoms that you might get from the patient, so breathlessness, dyspnea, breathless walking around, sort of new, different breathlessness for them. So, you know, if they're usually breathless and have been for years, say from COPD, we would be looking at a change, a worsening. Orthopnea is breathless when lying down. So we always ask how many pillows you're using. Can you sleep flat? Do you sleep propped up? Sometimes they'll go and sleep in the chair because that's how they feel they're breathing better. So we always sort of question about what their sleeping is like. PND stands for paroxysmal nocturnal dyspnea, but it basically means that they wake up from sleep feeling breathless. It's very scary. They'll know if they get it because they feel like they're drowning and they need to sit up. And what's happening is this is their lungs and they've got a bit of fluid in the bottom of their lungs and they're sitting upright. The fluid sits there, it doesn't really cause any problem. If they lie down, that fluid will spread out, the surface area is much bigger and all the airspace is filled with fluid and they can't breathe and they feel like they're drowning. They sit up and within a minute or two they feel better because all the fluid's gone back to the bottom of the lungs again. It's a classic heart failure sign. And then the other symptom is weight gain. So that's the importance of the weight, because if they're very heavily fluid overloaded or even just a little bit of fluid, their weight will go up. That fluid will weigh something. It's an abnormal body weight. We talk about dry weight in heart failure. What is their weight when they've got no fluid? We don't always know it, but often we can go back a few months. You can say to the patient, well, before all this fluid came, do you know what your weight was? And then you know roughly what you're aiming for. Any symptoms of new edema, so swelling in their legs, nearly always bilateral. If you've got one swollen leg and one normal leg, it's very unlikely to be heart failure. There's no reason why it would choose one leg and not the other. We often see swelling in both legs and one leg might be slightly worse than the other. That's often if a patient's, say, had a stroke that's affected one side, or they might have had bypass surgery and had a vein taken out of their leg. They might have had an ankle injury at some point or a knee replacement. There's nearly always a reason why, but you would still see swelling in both legs. And then look at their meds. Are they on diuretics? Are they on any cardiac medications or any medications for hypertension? Be wary of amlodipine. A side effect of amlodipine is swollen feet, so it can be a bit of a red herring, amlodipine. But so we're looking for clues as to whether they may have a cardiac condition going on. Check the medical records. There's all those terms again, as we just mentioned before, about how heart failure might be described in the notes. So if you think heart failure is a possibility, if they've got any of those symptoms or any of the past medical history, there's a very simple blood test that can be done called an NT-proBNP, and it's done in a gold top tube, the yellow one. If the result comes back at less than 400, it's definitely not heart failure. You do get a rule out with BNP, which is why it's quite nice to do, because if it's less than 400, you're very sure it's not for heart failure and you're safe to go ahead and compress. If the level's between 400 and 2000, GP can wait for 6 week, refer them for 6 week wait cardiology clinic. And if the level is above 2000, then it's more than likely definitely heart failure, and they will refer for a 2 week wait cardiology clinic. And this is still me, yeah. So there's the first blue box there. It's got everything I've just covered. So get them to do the BNP. I think we've covered all this actually, haven't we? So there's that small part in the red box. If it's a yes, there are red flags. Get the GP to do the BNP. If the leg is weeping and you don't want to wait for the BNP result, and you need to get something on the leg, just use K soft or K light until the results are available. Leg elevation, always try and get the patients to put their feet up. They'll sit with their feet flat on the ground, or they've got a little tiny stool and they say, I've got my feet up, but the stool's about this big. They really need to have their feet at hip height, preferably slightly higher, but try. And then I always encourage them to pull their feet up towards their chest, because it helps pump that muscle of their calf, and it will get the fluid back into the veins and pump it back up. And then if that's the case, refer to tissue viability. And if they've got reduced ejection fraction, so ejection fraction less than 40%, refer to us. If you're not sure, just ring us, because we'll be able to look up the results anyway, and let you know. And if they've got none of those red flags, then you can commence compression in line with the chronic edema pathway. And this is still me. So if there's already a diagnosis of heart failure in the records, so you've looked at the records and you can see they're known heart failure. So have they had a recent heart failure admission? Is the heart failure unstable? Is it recently decompensated? We need to try and work out how severe their heart failure is at that time. Are there any concerns about any fluid overload? Have they got worsening edema? Are they waking breathless? Can they not lie down? Are we actively increasing their diuretics? If you've got any of these, then they're fluid overloaded, then we shouldn't be compressing them. You'll need to discuss with us or the GP. We need to be optimizing their meds and getting them stable from a heart failure perspective before considering compression. So if there's no concern, yes, they've got a diagnosis of heart failure, but they're very stable, the meds are unchanged, then we're not seeing them and there's no concern about any of their symptoms, then you can implement compression with a risk managed approach that we're going to come on to. But if there's any worsening heart failure, then you shouldn't be applying compression, but speak to us. And because it's good to liaise, because once we've got them stable, then we would be able to say, yep, now's a good time to try the compression, but we need to know that we've got rid of all that excess fluid first. Penny.
Brilliant. Thank you, Jenny. So where we've got to, let's just go back to there. So we've got to, yes, this person has got heart failure. We've got it all under control. And now we're at the point of, OK, this is as good as it's going to get. We want to put some compression on, but we know that we still need to be careful. So we take this sort of risk managed approach to putting sort of compression on. So this advice is on the back of that pathway. So again, the document on the website, you will find this risk managed approach on the back of it. OK, so it takes a step-by-step approach, and you need to do close monitoring as you're doing it to see what the impact of the compression is on the heart failure symptoms. So this is why it's really important to do those baseline observations at the beginning, and we'll show you the monitoring documentation in a minute, but there's a monitoring form to go with this so that you can monitor the patient as you're going along. So that's the blood pressure, the pulse, respiratory rate and weight. And then we're going to start the compression gently, and we're going to increase it in stages. And we do that in a number of ways. So you will start with one leg first and then move up to both legs. You might start with below knee, and then if it's thigh length that you need, you would then work up to the thigh length. And you might start with a lighter form of compression and work up to sort of firmer forms of compression, so that you're not going straight from 0 to the max all in one go. So you're not sort of shifting the fluid like a great big tsunami, you're just gradually moving it back in, so the heart doesn't have such a large volume of fluids to deal with in a short amount of time. And you will, as you're doing it, you'll be evaluating as you go along, and seeing how you're going. We suggest that now how you do that depends again upon how severe the heart failure is, what the element of risk is judged to be. We had somebody referred to us this week where it sounds really risky, and we know that it's sort of fairly palliative heart failure, but legs are weeping, and so we're being really extremely cautious on how we do things. But then you'll be seeing patients that have well under control heart failure, and you might not need to be as cautious. So these are principles that you will apply. We would suggest that you start the compression at the beginning of the week, so that if there are any consequences and you're destabilizing anything, it's not going to be over the weekend when you're into out of hours services. And likewise, aim for applying the compression, or at the beginning anyway, at the beginning of the day rather than the end of the day. So if it does cause problems, it's not going to happen in the middle of the night, and you'll be on duty, and the patient will be able to call yourself or the GP or Jenny or one of the team for some advice. And you need to make sure that the patient can either call for help or has somebody that can monitor their condition. So if you've got somebody with capacity and a telephone, you'd be able to say to them, okay, so if you feel that any of your symptoms are getting worse, either you can take the top layer of the bandaging off, or you can call somebody, this is the number, call somebody, explain what's happened, and get somebody to come and see you. Either that, or they've got a carer or a next of kin or somebody that will be able to monitor and do that sort of for them. So this is the monitoring document, and the idea would be that if you're taking this route with somebody with heart failure, if they're open to, or they've got the correct type of heart failure that Jenny was talking about, that the heart failure service are involved with them, that you'd be negotiating and contacting the heart failure team and saying, right, we're going to start compression on this person. These are the baseline OBS. Do you want to be involved in the monitoring? Are you going to speak to the patient first and review it before we start? I'll fill in this form and we can communicate with you about any sort of changes. So you would be putting the heart failure nurse's name on the sheet and their contact number. It's actually on the bottom of the sheet, the contact number anyway, and your contact details as well for the patient too. So the top of the form there, you see you've got your baseline observations, as well as doing the blood pressure and the like. We've also got here whether somebody's short of breath at rest, short of breath on exertion, whether they've got that paroxysmal nocturnal dyspnea, whether they have got orthopnea, what's happening with their cough. And in case you are unfamiliar with all those terms at the top of the sheet there, the bottom page, the reverse of this page does explain what these symbols stand for and what it means. So if you're not familiar with these terms, it is on the reverse side of this sort of sheet of paper. And then here on the right side of the form, you're going to be recording what type of bandage that you've put on, whether it's half leg, full leg, one leg, two legs, so that you can see retrospectively, you can see how the symptoms have been responding to the levels of compression that have been put on there. So you're going to be, as Jenny said, you're going to be looking for any worsening of these symptoms. You would be looking for things like the legs are getting smaller, but the patient isn't losing weight. So with the compression, we would expect to be moving some of the fluid back into the circulation, and we would then hope that the heart will pump it around the system and the body will get rid of it, and that therefore somebody would start to lose weight. But if they are not losing weight, but the legs are getting smaller, that again would be something to be concerned about, and something to escalate. So this is the monitoring form, and again this is on our website and the same place next to the pathway. They're two separate documents. So as we said, you're looking for any worsening of the symptoms of breathlessness at rest, breathlessness on exertion, orthopnea, the PND, new cough, and as I said, the weight gain or reduction in limb size without weight loss. And you'd be contacting the heart failure nurse. And again, this is the information that's on the back of the form there. And as you can see, the abbreviations are explained. Contact details for the heart failure team are there. Any questions?
Is it sensible to do baseline observed measurements of the leg before we start compression, or is that not really necessary if we're doing?
Yeah, absolutely it is. And if you look on your wound assessment and care plan documentation, and you'll see where the holistic lower limb assessment tick boxes and your Doppler and things, it does have a space there for the baseline measurements of the limb. But if you've got somebody with chronic edema, there is a lower limb measurement form so that you can see if what's happening to the limb as you're decongesting it, or if you've got somebody with heart failure diagnosis, you'd be using this form. But yes, you would be doing those measurements. Yes, you should be measuring all legs that you're putting compression on to make sure that you're putting the right type of compression on and that you've got a graduated shape as well. Anybody else? What do you think? Do you think this is going to be helpful?
I think it's going to be great, and it's going to save a lot of time to and fro with GPs asking whether or not we can compress, and they agree to it, because quite often they just say no regardless.
And I always say to people, you know, that managing leg ulcers, managing lower limb edema, we are in the realm of, this is a community nurse's speciality. We are the people that know the most about this stuff, rather than GPs and the like. And it's not always helpful. I mean, okay, of course, you know, you obviously need to be communicating with GPs about could we do a BNP? I think that there are some risks. How stable is the heart failure, etc. But ultimately, I think we need to own this stuff and recognise that we are the people leading this care. That you've got guidance on what to do, and to sort of, you know, to run with that.
Do excuse my ignorance, do district nurses need the permission from the GP to do a BNP, or can you just do it anyway?
I would sort of say, sorry, I can see people have got their hands up. I'll bring you in at the moment. That the permission of the GP, they are actually paying for the blood test. So we get told off sometimes and have to eat humble pie because it is them that's paying for it. So Kay, you wanted to say something about that?
Yeah, so any blood test can be requested. However, it's the governance on who is going to check it, who is going to action it. So you have to be very sure that it is the responsibility will sit with the GP generally. Heart failure nurses request bloods and they follow up, and they've got a cardiology consultant for support. So yes, we should ask them, because it's an indicator, because they're going to have to take responsibility for what is going to happen. So I would suggest yes. Sorry, I just had to jump in there.
Thank you.
But if you can pick up heart failure early, if you get a patient that you didn't know had heart failure and they've got swollen legs, got the red flags, and you pick up they've got heart failure, you're going to buy that patient a couple of years. You're going to be preventing loads of admissions to hospital, improving, well, the symptoms that they haven't got, they're not going to get. I mean, the earlier it can get diagnosed, the better. And it is one way of diagnosing heart failure is somebody with new swollen legs.
Oh yeah. So I just got a quick question. One of our patients, she's not got a diagnosis of heart failure, but she has got ischemic heart disease and she's on many tablets and stuff. So she's got bilateral leg swelling, ulcers. Would you suggest that the next step for her then would be to get that blood test done, leave her in case of K-Lite until we get that blood test done, and then if that's okay, she can go into Coflex? Or
Definitely get a BNP blood test done.
It's really interesting. Once you really tune your eyes into this sort of stuff, you'll end up picking up quite a lot of patients, I think. Anybody else with a question? I mean, I don't know whether you want to say, Jenny, about because I can see everybody's going to go out and anybody with edema is going to get a BNP requested. Is there any mileage if people have already got a diagnosis of heart failure of doing the BNP blood test again?
No, if you already know they've got heart failure, the BNP will come out raised and it won't add anything to what you already know. So if you know they've got heart failure and you think that their condition is not being well managed or optimized or whatever, get in touch with us. Even though we don't see the HFpEF patients, our hospital colleagues can see them, not as regularly as we would, but we can get sort of follow-up care for them. But no, there's no point in doing a BNP in someone you know has got heart failure.
Okay, so it's purely a diagnostic thing,
yeah,
not a monitoring thing.
Yeah.
So yeah.
Dad, we talked about on the monitoring form to liaise with your locality heart failure nurse. There are 8 of us for the whole county. We do work in localities. It's probably easier initially to ring that central number on the screen or email, because if someone's off sick or we're covering for annual leave, rather than you trying to get hold of somebody who's not in. So go via our central number that our admin will deal with first, and then you'll be directed to the correct person who's managing the patient you're looking after. And keep in touch. I know it's frustrating that we don't see all heart failure patients, and I'm hoping that would change. But in the meantime, if you're not sure if they're suitable for us or not, just ring. We'll soon tell you if it's us or not, and we'll be able to give advice anyway. We just wouldn't be able to take them on our caseload if they don't meet our criteria. So yeah, don't be a stranger. Just give us a shout.
Brilliant. Thank you, Jenny.